Hello, good evening. Welcome to the fifth edition of the National Neonatology Forum Monthly Journal Club. I'm Dr. Saurabh Datta. I'm chair of the NNF Research Committee. This is an activity that we started this year, and it's turned out to be a very popular exercise. So each month we select a recently published article, and we have been choosing different kinds of articles, RCTs, observational studies, diagnostic tests, and this time it's a meta-analysis, uh, which is presented by a host institution. Different institutions volunteer by turn. There's an external expert who discusses the methodological aspects. Then we take up questions from the participants. Uh, in this session, we are particularly fortunate that we actually have the lead author of the paper, Dr. Joe Falk, who is a consultant neonatologist at the University Hospitals Leicester NHS Trust. He's also the vice president of the Resuscitation Council of the UK and chair of the Resuscitation Council of the UK Newborn Committee and an ILCOR task force member. We are really pleased to have you with us, Dr. Falk. It's going to add a lot of depth to our discussion.
Thank you
Uh,
for inviting me.
you're welcome. The host institution this time are the Surya Hospitals Mumbai, which, as you know, is a leading hospital in the private sector, and they also do a lot of very interesting academic work. In fact, they are prolific at publishing systematic reviews. I have the pleasure of welcoming Dr. Nand Kishore Kabra, who's a very senior neonatologist at Surya Hospitals. He's formerly trained in clinical epidemiology at McMaster University in Canada. And uh, I welcome you, Dr. Kabra. The external expert is going to be Dr. Veera Raghavan. All of you know Dr. Veera Raghavan and his tremendous expertise in systematic reviews and meta-analyses. He's also a member of the task force of ILCOR and a very active teacher and trainer in the field of systematic reviews in India. I now hand over to Dr. Kabra to tell us why this article was chosen and to introduce the speaker, who is none other than his own student. Over to you, Dr. Kabra. Dr. Kabra, can you unmute yourself? Dr. Kabra, please unmute yourself.
Can you hear me now?
Yes, we can hear you.
Yeah. So good evening. The reason for choosing the article was it's one of the most commonly done procedure in sick newborn is intubation, and sometimes we face difficulties. And because this is a newly published systematic review which answers the question of interest, so that's why we chose this article. And it will be presented by Dr. Abhishek, who is our second year DRMP neonatology trainee. Abhishek is academically very active, and recently he was involved in publishing two systematic reviews and meta-analysis. One was on minimization of blood sampling, which was published in Archives, and second was on whether to do surgery at um, primary hospital or whether to refer to surgical hospital. That was published in PLOS. Now, from my side, Abhishek, you can go ahead with the presentation.
Abhishek, you can share your screen and start the presentation.
The screen visible, sir.
Yeah, the screen is visible. You're audible. So you can make it full screen. I think it's already full screen. Yeah,
Okay, yes.
please go ahead.
Good evening, everyone. Good evening, NNF faculty and colleagues. Firstly, I would like to thank all the NNF faculty, Dr. Saurabh Datta sir, Dr. Kabra sir, and Dr. Veera sir for giving me this wonderful opportunity to present on this platform. So we have selected this topic. The title of the study is Video versus Traditional Laryngoscopy for Tracheal Intubation at Birth or in the Neonatal Unit, a systematic review and meta-analysis. So the study details, the author being Dr. Joe Falk et al. The design is a systematic review and meta-analysis. It was published in Resuscitation Plus in April 2025. So coming to the introduction. So as we know, tracheal intubation is important to secure the airway, optimize oxygenation, and achieve adequate ventilation. And it has been seen that about approximately 0.4 to 1.2% of neonates require tracheal intubation immediately after birth, and up to 20% of critically ill neonates in NICU. An international registry in 2019 published a report reported that the first attempt success rate for tracheal intubation in the delivery room was only about 46%. Neonatal tracheal intubation is also associated with several complications, such as delayed recognition of esophageal intubation, laryngospasm, air leaks, airway trauma, severe desaturation and cardiac arrest, and these are the reported risks. And the incidence being 18% for neonatal tracheal intubations, and center-specific rates varies from 9% to 50%. So there has been concerns regarding the declining competency with respect to neonatal intubations, as there is a major shift towards shift of change in practice from invasive to non-invasive management in the neonatal care, thus reducing the number of endotracheal intubation. Now coming to the video laryngoscopy. So this availability of video laryngoscopy facilitates the training and performance of the procedure in the clinical setting. It is also useful for the infants with difficult airway, and it allows the visualization of glottis without requiring alignment of the operator's line of sight with the laryngeal inlet. Video laryngoscopy use was first reported in neonates in 2009. Since then, the use of video laryngoscopy has increased in many centers in Europe, North America, and in Asia. Cochrane reviews has been published. First, a Cochrane review was published in 2015, comparing video laryngoscopy versus direct laryngoscopy in neonates. In 2015, there were no RCTs were found. Later in 2018, three randomized control trials were found, and the results were moderate to very low certainty of evidence for first attempt success rate for intubation with video laryngoscopy. Later in 2023, this Cochrane review was updated and 8 randomized control trials were identified. This included neonatal intubations in delivery room, operating room, and in NICU. They only included randomized control trials and no observational studies were included. The results of 8 RCTs revealed that the success of tracheal intubation on the first attempt may increase and may result in fewer intubation attempts, but it may not reduce the time required for successful intubation in the delivery room, operating room, or in the NICU. So this Cochrane review reported some limitations with respect to these studies. First was the small sample size. Second, it was they were not able to assess the risk of bias in some studies as the results varied. And third, there was high risk of bias with respect to performance bias, that is allocation concealment. Recently, another systematic review and meta-analysis was published in European Journal of Pediatrics. This included 13 randomized control trials, of which 7 studies included only neonates and 6 included infants less than 11-month-old. Here also the results were similar, and the limitation being more of heterogeneity was noticed, and the authors concluded the need for further studies to improve the first intubation success rate in neonates. In 2021, the American Academy of Pediatrics and National Resuscitation Program stated that a video laryngoscope may be a helpful device for training noise operators and for intubating a baby with a difficult airway. Objective of this systematic review is to compare video laryngoscopy with traditional laryngoscopy to improve the success of resuscitation prioritized by ILCOR committee and National Life Support Task Force. In the methods, the protocol of the systematic review was registered prospectively in Prospero, and the study was reported as per PRISMA guidelines, that is preferred reporting items for systematic review and meta-analysis. The cost question. Here the population is that infants receiving tracheal intubation at birth or on neonatal unit, intervention being video laryngoscopy, comparator is traditional laryngoscopy, improved success is the outcome. S and T, S is the study design and T is the time frame. So coming to the outcome, the primary outcome was successful tracheal intubation rates, and the secondary outcome was successful tracheal intubation at first attempt, number of attempts to achieve successful tracheal intubation, time taken to successfully intubate, adverse events attributable to laryngoscopy, perception of intubating clinician, and in hospital mortality. Subgroup analysis was also planned with respect to following factors. First is the location of tracheal intubation, whether it was in delivery room or in the NICU. Second, type of intubation, whether it was emergency or elective. Then gestational age at birth, experience of person performing the intubation, and type of laryngoscope used. Now coming to the search strategy. A comprehensive search was done from the inception dates to 13 November 2023 in various databases, that is Ovid Medline, Embase, Cochrane Controlled Register of Trials, and CINAHL, without any language restrictions. The search was updated on 22nd August 2024. Additionally, the NLM Trial Registry and International Clinical Trial Registry platform were also searched. 49 study registration were found, but none led to any additional studies for full text review. Study selection and data extraction. Randomized control trials, quasi-randomized control trials, and observational studies were eligible for this review if they address the study question. There were no language restrictions provided if there was an English abstract. And the exclusion criteria was those studies which included preoperative intubation or studies of video laryngoscopy specifically used for difficult airways. Covidence systematic review software was used for study selection. Pair of independent reviewers screened titles and abstracts. Subsequently, two independent reviewers assessed full text articles for eligibility. Primary reason for exclusion were documented. Pairs of independent authors extracted predefined study characteristics and outcomes. Study authors were contacted for clarification when necessary. All discrepancy between reviewers were solved by consensus of all reviewers. Risk of bias. In order to identify potential systematic error in study design, conduct, and analysis, risk of bias was done using ROB version 2 tool for randomized control trial and Robbins 1 tool for observational studies. The risk of bias was assessed for each outcome in randomized control trials and at study level for observational studies. The confidence in the effect estimate, that is the certainty of evidence, was evaluated using grade framework, and it was done for each outcome using grade pro software. So this grade framework has 5 domains, that is risk of bias, inconsistency, imprecision, indirectness, and publication bias. So all these 5 domains will be rated from serious to not serious to very serious, and the certainty of evidence will be graded. Now coming to the data analysis, the Review Manager version 5.4.123 was used to analyze data. RCTs and observational studies were analyzed separately. Meta-analysis was performed if 2 or more studies of similar design, evaluating the same intervention and outcomes, and reporting sufficient data were available. For dichotomous outcomes, pooled unadjusted risk ratio and corresponding 95% confidence intervals were calculated using Mantel-Hansel random effect method. Forest plots were generated to graphically represent the relative risk. The absolute risk difference and its confidence intervals were also calculated. Heterogeneity was assessed using I-square statistic, and if the I-square statistic was more than equal to 50%, then it was considered to be significant. Clinical impact of findings is expressed as in other ILCOR NLS task force reviews using modified grade explanation of treatment effect. Now coming to the results. So this is the Prisma flow diagram. Here, 1,264 records were identified and imported into Covidence from databases such as PubMed, Embase, Cochrane, CINAHL, and clinical trial registrations. Title and abstracts were screened, and 59 reports were assessed for eligibility, of which only 10 studies were included in this review. Out of 10 studies, 6 were randomized control trials and 4 were observational studies. So here, this review differs from the previous Cochrane review, which had enrolled 8 randomized control trials. There, they had included 4 studies, which had studied intubation in the operating room, which was done by the anesthesiologist. So those 4 RCTs have been excluded in this review. Now coming to the study characteristics for the randomized control trials, the following data were collected. That is the intubation rates, gestational age, pre-medications, the blade used, and the intubators. Summarizing these study characteristics for the randomized control trials, total intubations were 862. There were 82.8% intubations in the NICU, 17% in the delivery room. Median age ranged from 29 to 32.8 weeks, and the pre-medication rate also ranged from 39 to 100%. Most of the intubators were resident doctors. Also, trainees and neonatologists were also present. So these are the study characteristics in the observational studies. So total intubation in these observational studies were 3,342. 95% were intubations were in the NICU. 4.9% intubations were in the delivery room. Median gestational age ranged from 28 to 38 weeks. And pre-medication rate varied from 73 to 100%. Now coming to the reported outcomes in the randomized control trial. So they had reported successful intubation and successful intubation at first attempt. So if here we can see the successful intubation varied from 57 to 76% in the video laryngoscopy group, whereas in the traditional laryngoscopy group, it ranged from 33 to 63%. And successful intubation at first attempt ranged from 30% to 74%, whereas in the traditional laryngoscopy group, it was from 15 to 45%, which was less. In the observational studies, here we can see the successful intubation was reported in only one study, which had 100% success rates in both the groups, and successful intubation at first attempt was higher in the video laryngoscopy group compared to the traditional laryngoscopy group. Now coming to the pooled results of these studies, for firstly the randomized control trial. Here for the first outcome, that is successful intubation. So there were 71% successful intubation in the video laryngoscopy group, 51% in the traditional laryngoscopy group, and the relative risk was 1.43 with 95% confidence interval from 1.15 to 1.77. And the absolute risk difference and number needed to treat, which was significant, that is 220 more successful endotracheal intubations per 1,000 intubations with video laryngoscopy, and the number needed to treat was around 5. However, the I-square, you can notice here, it was 50%. The second outcome, successful intubation at first attempt, 59% was in video laryngoscopy and 49% in traditional laryngoscopy. Relative risk was significant, that was 1.57. And the absolute risk difference and number needed to treat was similar. Heterogeneity was 0%. If you look at the mortality, which was less in both the groups, and it was not significant. Coming to the graphical representation of relative risk. Here, for the first outcome, that is successful intubation, 4 studies were included, and total video laryngoscopy events were 206 out of 290, 142 in the traditional laryngoscopy group, the RR being 1.43. And if you look at the effect estimate, that is the diamond which is crossing 1, favoring the video laryngoscopy group. The p-value is significant and the I-square is 50%. The second outcome, that is successful intubation at the first attempt. Here, 4 studies were reported. In the video laryngoscopy, events were 186 out of 313, 117 in the traditional laryngoscopy group out of 297, RR being 1.56, and the effect estimate was significant, crossing 1, which favoring video laryngoscopy group, p-value being significant, and the heterogeneity is 0%. Analysis of adverse events in the randomized control trials. Following adverse events were reported, that is bradycardia less than 60 beats per minute, heart rate less than 100 beats per minute, oxygen saturation less than 80%, esophageal intubation, airway trauma, and pneumothorax. All these were not statistically significant. However, oxygen saturation less than 80% and esophageal intubation was comparatively lesser in the video laryngoscopy group compared to the traditional laryngoscopy. Coming to the next outcome, that is perception of intubating clinician. 2 RCTs reported this outcome. In one RCT, they reported in the form of 5-point confidence score, which was developed by the authors. And they reported that overall confidence was higher with video laryngoscopy compared to the traditional laryngoscopy, as reported by trainers, trainees, and other members of intubation team. And another RCT, that is MOSA, reported some issues with the devices. One is the difficulty in intubation was slightly higher in the traditional laryngoscopy group. Inability to visualize the glottis was also higher in the traditional laryngoscopy group. And blade was too big, which was more in the video laryngoscopy and none in the traditional laryngoscopy. The next outcomes, time to intubate and number of attempts to intubate. Here, the data could not be pulled because of important differences in how data were reported in each study. One RCT reported the time to successfully intubate on first attempt. 3 RCTs reported the time for each successful intubation attempt, but cumulative time to successfully intubate the patient was not reported. So this is the risk of bias for a randomized control trial. Here, Cochrane risk of bias 2 tool was used, which has 5 domains, that is randomization, deviation from intended intervention, missing outcome data, measurement of outcome, selection of reported result. So here each outcome were assessed for risk of bias, and this color coding represents, that is green says the low risk of bias, yellow is some risk of bias, and the red is high risk of bias. So there are various risk of biases for different outcomes. So if you look at the relative contribution of randomized control trials with different risk of bias towards the overall risk of bias, for the first outcome, that is overall intubation success, the Gerardi and Musa study contributed around 30 to 40% for low risk of bias, and overall being 71.1% for low risk of bias. And the second outcome, intubation success at first attempt, again Gerardi and Oshia, they contributed higher weightage for low risk of bias, and the overall percentage of studies for low risk of bias contribution was 83%. Now coming to the risk of bias for observational studies, here Robbins 1 tool was used. So this tool has 7 domains and 4 studies were assessed. Here the green represents low risk of bias, yellow is for moderate, red is for serious risk, and gray says critical risk. So here overall 3 studies were graded serious risk, and 1 study, that is OSHIA, was having critical risk of bias. Now coming to the certainty of evidence. For the first outcome, that is successful intubation, 4 studies were included, and for the out of 5 domains, as I mentioned earlier, Serious was graded for inconsistency. That is, the results varied among the studies, which was inconsistent. Hence, certainty was downgraded to moderate, reporting as moderate certainty of evidence. For the second outcome, that is successful intubation at first attempt, of 4 studies, none were serious, that is, all were not serious. So the certainty of evidence was high. So if we look at the risk of bias in the previous slide, here the one study, that is OLS 2018, has high risk of bias in most of the study outcomes. So by removing this study, a sensitivity analysis was done and the effect estimate and confidence interval were similar and did not change much. Subgroup analysis. There was insufficient data to perform subgroup analysis with respect to site of intubation, type of intubation, gestational age, experience of intubator, and type of video laryngoscope. Into the discussion, the main findings of this systematic review is that there was successful tracheal intubation, and successful intubation at first attempt was more likely with video laryngoscope than traditional laryngoscope, which was supported by grade assessment that RCT findings had moderate for successful intubation and high certainty of evidence for first attempt success. Though large observational studies had low certainty of evidence, but they supported their increased risk at first attempt when tracheal intubation was done with video laryngoscopy. And RCT data could not rule out difference in rate of adverse events, while data from observational studies show that esophageal intubation was less likely with video than traditional laryngoscopy. So in the present review, one more outcome, that was time to intubate was not pooled because of the heterogeneity seen in the approach to defining this time interval and potential confounding introduced by variation in the time until a senior clinician took over the procedure. Also, the results from the previous Cochrane review found no important effect with respect to video laryngoscopy on the time to complete the intubation procedure. Coming to the key strengths of this systematic review. So this was LCOR initiated, and the review was prospectively published, registered in Prospero, which was the protocol was developed by ILCOR and NLS task force. The systematic review was reported as per PRISMA guidelines. It was a comprehensive literature search developed in consultation with an experienced librarian. All the duplicate screening and was done, and they were removed, and data extraction was done. Risk of bias and certainty of evidence assessment were done using contemporary tools. There was a clear separation of RCT and observational data to ensure methodology rigor. The largest study, that is JRT 2024, which was published in NEJM, enrolling 226 infants, was included. This review also covers the data of different situations, that is delivery room and the NICU. Also included data on trainees who are actually present in delivery room and NICU when the intubation is required. And conclusions were developed by the consensus of NLS task force and approved by ILCOR committee. This review has a few limitations. One is the sample size, that is 862 is modest for safety outcomes like mortality, airway trauma, esophageal intubation, severe desaturation, and bradycardia. Most intubators were trainees and inexperienced, so results may not be generalizable to trained and expert hands. And pre-medication rates varied from 39 to 100%, which is wide. And different studies use different blade type like hyperangulated or stillate assisted technique, which are not universally available. Also, cost effectiveness was not looked at. Data on long-term neurodevelopmental outcome was also not looked at, as it was a neonatal trial. Several of included RCTs focused on training noise and inexperienced intubators, and all were conducted in high-income countries. So there may be some limitations of external validity to those who already have considerable experience and to other settings. Coming to the knowledge gap, the intended subgroup analysis could not be conducted due to insufficient data. All the included studies in this systematic review were conducted in high-income countries. No included studies evaluated cost effectiveness of video laryngoscope, which are important because cost issues may restrict the feasibility of implementation in low resource settings. Additionally, the development of standardized scoring systems for duration and difficulties encountered and outcome of intubation may assist future research. Coming to the conclusion, video laryngoscopy significantly improves overall success rate of intubation and first attempt to intubation, supported by overall moderate to high certainty of evidence. The benefit is more likely when the intubator is more inexperienced. Video laryngoscopy may be beneficial where available resources for purchase and subsequent training allow. Based on these evidence, ILCOR recommendation was given in 2025. First, where resources and training allow in infants being intubated at birth or in neonatal unit, the use of video laryngoscopy compared to traditional laryngoscopy is suggested, especially in settings where less experienced clinicians are intubating. So this was a conditional recommendation with moderate certainty of evidence. The second was a traditional laryngoscopy should always be available as a backup device, which is a good practice statement. Thank you.
Thank you very much, Dr. Abhishek, for that excellent and comprehensive discussion of the article. I would now invite Dr. Veera Raghavan to tell us, to educate us about some of the methodological aspects of systematic reviews and meta-analysis in general, with the focus on this meta-analysis. Over to you, Veera. Do you want to share some slides, Veera?
Thank you, sir. I'll share some slides. I think most of the things were covered by Dr. Abhishek. Uh, my screen is visible, sir?
Yeah, it's visible. Yeah.
Okay. So, just covering the basics of systematic review and meta-analysis in, say, 10 minutes is quite difficult. But because this is all about basics of research, we'll only touch upon a few topics. If you have doubts, do put it in the Q&A section. So, a systematic review project, it starts with a research question. It's just a recap of what Dr. Abhishek had already presented. The research question is usually in the form of a PCOST. All of you might be aware of the PCOT format from the previous journal clubs on RCTs. So we have two additional components: study design. That is whether what the authors they prefer to include, what designs they prefer to include. In this case, both RCTs and observational studies were included. And T stands for the time frame of the literature search. Once your PCOST is formulated, you move on to writing the protocol and then registering the protocol a priori. So Prospero has been traditionally the go-to place where systematic review protocols are registered. But Open Science Framework is a promising platform, though underutilized. And some authors do publish their protocol in journals. Once a protocol is registered a priori, uh, then a systematic search of the literature is done. That's why it's called a systematic review. It's not called, we don't call it a review or a traditional review or something. It's called a systematic review because all these steps are done in a systematic way. The systematic search of literature is done, and it is suggested or recommended by the Cochrane Handbook that at least three databases be searched. The most important databases that we need to search include Medline through the interface of PubMed, Embase, and Cochrane Central. But most often, we search a variety of databases, as seen in this systematic review, which may include Web of Science, CINAHL, trial registries, and grey literature. ILCOR has a policy of not searching grey literature. But grey literature, what is grey literature? It includes conference abstracts, preprints, letters to the editor, and so on and so forth. Why do you need to search a trial registry? That's a question that you might be thinking. It has two purposes. One, you might be planning to actually finish your systematic review when you get to know that the recruitment is over and you contact the trial authors and you get to know that the paper is in publication phase, or they have submitted for publication. So you might wait, it might be a very large study. The second aspect is you might find so many studies on a similar PICO being registered in the trial registries but have not been published since years. So that might indicate that there is some publication bias related to this PICO in which you are interested. So these are the two purposes for which we search the trial registries. Uh, then we move for once the search of the literature is done, preferentially by an information specialist. We can call him a librarian also, or a research librarian. It is he or she who actually uploads the hits or the number of studies. In this case, I think it was 1,234 into online platforms. Many are available, but the most commonly used ones are Covidence, as in the systematic review, and Ryan QCRI. Uh, Once they are uploaded, as Dr. Abhishek told, I just wanted to add a little bit upon to that. Uh, Two authors screen, and they are involved in the selection of the studies independently, and they are blinded to each other. So the first author will not know what is the second author is doing, and these all will be reflected in these platform online platforms such as Covidence. And almost always you will have discrepancies, and which will be sought out through consensus or by a third senior author. After you select the studies, then you move on to extracting the data from the study and validating the data that you have extracted in your data extraction sheet. Then the risk of bias assessment would be performed again independently by two others, blinded to each other, and almost always it's a norm to have discrepancies, especially when you are using something like Robin's I tool. It stands for risk of bias in non-randomized studies of intervention. It's a very difficult tool to apply because it's quite subjective. So one author might say this study is at moderate risk of bias. The other one might say it is at critical risk of bias. Now you have to come to a consensus. That's why these things are done independently and they are blinded to each other. Now comes the question of whether this systematic review, whatever studies that have been identified in this systematic review, should we proceed ahead with the meta-analysis or not? So, amongst the students, there is always a doubt. What is the difference between a systematic review and meta-analysis? So, a systematic review may or may not be accompanied by a meta-analysis, but a meta-analysis is always accompanied by a systematic review. In this study, the outcome of time to intubation was not pooled. Okay, so it was not, I'll say, meta-analyzed. Why? Because the data was quite heterogeneous. That's what Dr. Abhishek told, or that's what is written in the paper. So what is the next option? You just leave it? No. You go for narrative synthesis. What is narrative synthesis? You just narrate what the study authors have actually reported in your results section. The last and the most important aspect is assessing the certainty of evidence behind each of the effect estimates for all the outcomes through the validated grading of recommendations, assessment, development, evaluation, uh, working group guidance, the grade guidance. Okay, so this is the overall view. I do not want to waste further more time talking about this. If anyone has any doubts, please put it in the chat box. Uh, Now, coming to the basics of a meta-analysis. So, while you are writing your methodology a priori in the protocol, you have to mention whether you are going to use a fixed effect or a random effects model. So, what are these models? So, Dr. Abhishek had displayed a forest plot of that Cochrane review where they had used a fixed effect model. And in this particular paper, a forest plot from this paper was also displayed where a random effects model was utilized to pool the studies. Now, what is the difference? A fixed effect model assumes that all the studies, say for example, you got two studies, one conducted in India and one conducted in UK. The fixed effect model assumes that both the studies are similar in all aspects. Whatever heterogeneity or variation that you're observing between these studies, which we call between study heterogeneity, is purely due to chance or sampling error. Okay, so uh, this is a very idealistic kind of a concept. Yes, of course. I mean, this has been adopted by Cochrane since many years now. They are moving towards random effects model. Now, what is the difference in random effects model? Random effects model also assumes that, of course, you are actually uh, estimating studies that are quite similar, but there are differences between these studies that are not purely due to chance. There are actual differences. For example, a study conducted in India, the population is different from the population in UK. The ethnicity is different. How the intervention is instituted, the experience of the person who is actually intubating with a video laryngoscope. So there are actual differences between these studies. So it is not just purely due to chance. So it adds another factor into it, which is called the toss squared. Okay, I hope I am not. It does not sound Greek to you. So fixed effect is when if it's an idealistic situation. Random effects is a pragmatic approach, most oftenly used by authors of systematic reviews, but always state a priori what you're going to use. You can't manipulate your reporting based on what you like, because both of the effects will give different results. No, Dr. Abhishek had mentioned Mantel-Haenszel method, and what is it? What is this Mantel-Haenszel method? And there is another important method which is called the generic inverse variance (GIV) method. What are these? So in the forest plots, you saw the weightage assigned to the studies, right? So meta-analysis is not just averaging the studies and calculating the mean. It's about assigning weightage to each study, and based on that weightage, you get a final effect estimate. So the overall weightage is 100%. So if there are two studies, maybe one study would be given 60% weightage and the other study would be given 40% weightage. And the pooled effect estimate will be more towards the study with 60%, which has 60% weightage. How is this weightage given to the studies? That is done by these methods, Mantel-Haenszel method and GIV, generic inverse variance method. So where do we use MH method? In fixed effect model. So again, going back to that Cochrane forest plot, you will see MH fixed effect model. It's used for binary outcomes. And as I told before, because it is used in fixed effect model, it does not take into account the tau squared aspect. So studies that are large, they will have very little within study differences, right? Within study variance. Large studies are given more weightage. Very simple. And the 95% CI will be narrower when compared to a GIV. GIV can be used both in fixed and random effects models, and it is quite flexible. Okay, generic inverse variance. Again, I am reiterating the same aspect. So the weightage is 1 upon, divided by the standard error square, that is within study variance. Each study will have some standard difference that is reported, plus the additional tau squared. Okay. Now how tau squared is calculated, we will see. There are various methods to do so. In this paper, they have done so using der Summoning layered. But there are other methods. The most commonly used one is the REML method, restricted maximum likelihood estimator method, and then you have the Siddig Jonkman and all. We don't have to go in depth into that. DL is the most commonly used one, because when the Revman was when Cochrane introduced Revman, DL was the only method that was available. So traditionally we have been using that, but it has got lots of fallacies. So which methods to use, that we'll see later. At least model you decide a priori. A pragmatic approach would be to select a random effects model. This is the consensus as of present. Now, when does a random effects model does not work? When you have less than 4 studies, then the tau squared, which is the main aspect of the random effects model, which is not there in the fixed effects model, becomes highly unstable. You cannot rely on that. So if you have at least 4 studies or more, then uh, whatever random effects, whatever effect estimate that you are getting from the random effects model is reliable. Now, suppose only 2 studies were available. You had stated in your protocol that you are going to use random effects model. But with 2 studies, you cannot use the random effects estimate. So what do? You give the fixed effect estimate as well and report the fixed effect estimate. Because with 2 studies, the tau square is highly unstable. The effect estimates will be quite wide. It might not even make sense at times. And then you have to go for the fixed effect model. But be transparent in your reporting. So 4 or more studies, a priori you have decided random effects, go for it. But if you don't have enough studies, that is 2 or 3 studies, do both, show the differences, report the effect estimate of the fixed effect model. The measures of heterogeneity, the I-square statistic was highlighted by Abhishek. So I-square is actually derived from another measure of heterogeneity called the Cochrane's Q. Cochrane's Q, which I'll show in the porous, each and every forest plot you'll have this Cochrane's Q, but it won't be written as Cochrane's Q. So it's associated with many flaws. It is underpowered. That's why we keep a p-value of less than 0.1 as significant for Cochrane's Q. Then I-square statistic only it says relatively how much these studies are varying from how much variance is there between these studies, or how much heterogeneity is there between the studies. It's a relative measure. Then there is another measurement called H square, which will be given by softwares like R and all, but not in the environment. And the last one, we have been talking about this since the inception of the talk, the tau squared. Tau squared is the most reliable parameter. The only problem is it is difficult to interpret it. So you should know what is your effect estimate. In this case, it is relative risk. So it is easy to estimate. If your tau squared value, just remember this cutoff is less than 0.04, minimal or no heterogeneity. 0.05 to 0.15 moderate heterogeneity, more than 0.15 significant heterogeneity. This is for relative risk. But if you take mean difference, if the study reports mean difference as the outcome measure, then the tau squared values will be different for different mean differences. It might be different for if blood pressure is an outcome. It might be different if weight is an outcome. So it quantifies the absolute variance or differences between the studies. Very reliable, but with in the era of AI, it's not hard to interpret. But manually, if you have to write and calculate, it takes some time. But all these, except for H square, all these are in your forest plot, but we do not usually see. We oversee them. I think I'll show Joe in the forest plot. So
Dr. Veeraraghavan, just a gentle nudge because we are running a little
and
short of time.
I'll just run through, sir.
Yeah.
So we saw that how tau square is calculated. I don't want to go into prediction interval. This is my second last slide. So this was already shown. So this is the outcome. Is it a good outcome or a bad outcome? That's the first question. So this is a good outcome, right? Successful intubation. This is what you have to see. And the second thing that you can see is that they are reporting the risk ratio using the Mantel-Haenszel method in a random effects model. Very rare scenario where you use MH with random. I thought of asking Joe prior, but we couldn't have the time. MH is usually used with fixed and GIV is used with random. Okay, so you could have stated as one of the limitations, statistical limitations. Now, so I told you all these things. So MH method was used for giving weightage for the studies, and they were pooled in the random effects model. And these were the weightages. You can see how the second and the third study had the highest weightage. Why? Because they had a relatively higher sample size and event rate. Okay, so this is a line of no effect. The size of these squares represent the weightage, and the lines represent the 95% CI of each study. So this is the final pooled effect estimate, which is not the average, which is based on the weightage given to the studies. It is significant because it is not crossing the line of no effect, which is 1 for risk ratio. If it was mean difference, it is 0. So that's the p-value we already highlighted. So this is the Cochrane Q. Okay, they are not written Cochrane Q. They are given the degree of freedom, chi-square, and the p-value is 0.11. So it indicates there is no heterogeneity. Okay, I square is 50%. It's usually anyone, if you just read I square of 50%, you'll think that it has there's lots of heterogeneity between studies. But if you eyeball the forest plot, you can see that the point estimates of all the studies are towards the right. Okay, the confidence intervals are overlapping. So I wouldn't have downrated for heterogeneity in this case, and which will be supported by the tau square value, which is calculated by the D-Simon-Laird method. The tau square is 0.02, and the effect estimate is risk ratio. So 0.02 minimal variance between the studies. So Wall test is used to calculate the 95% CA. And grade, Abhishek had touched upon that. Just remember, whatever effect estimate it be, risk ratio or mean difference or odds ratio, always interpret the effect estimate along with the certainty of the evidence. If you have high certainty of evidence, that means that further trials are not going to change your effect estimates, and mostly it won't, your studies won't also get published. Moderate means you're reasonably sure that whatever is reported in this in the meta-analysis is close to the true effect, but there is a possibility that it is away from the true effect. Low and very low, usually we do not trust those results. Okay, and this has been shown here, moderate and high, and this is how we report based on the certainty of the evidence and the statistical significance. You can go to the grade paper and read it, because I don't want to take much of your time. And remember, it's not only Prisma, but you have Amstar 2 as well as a reporting guideline tool, which is much more stringent while evaluating the robustness of a RCT. These are the recommended books, and I thanks for the opportunity. I stop my talk here. Any doubts you can ask. I'll stop.
Yeah, thank you, Dr. Veera Raghavan. We'll be getting back to you because there'll be questions from the participants. But I think we are all really keen on hearing Dr. Joe Falk. Uh, uh, Dr. Falk, could you tell us what are the challenges that you faced while doing this meta-analysis? And
Yep,
uh, and are there some specific things now looking back at this meta-analysis that you would like to highlight and inform us about the whole process?
absolutely.
Please go
So
ahead.
thank you. Thank you very much. And Dr. Abhishek, thank you for presenting this work so clearly. So I thought I'd start by just exploring why did we actually do this work at all? Why did ILCOR prioritize it? So as Dr. Abhishek said, there was a number of Cochrane reviews that had already published suggesting that video laryngoscopy was helpful and improved overall intubation rates. So you might argue that some of that work had already been done. Now, what we wanted to explore was a more focused population. So we were considering people who were intubating in a neonatal setting, so either in the delivery room or on the neonatal unit. And the reason we selected that is it's a very different group of people if you start expanding that into the operating room. So there you'll generally have anaesthetists who've come through an anaesthetic training pathway who will be intubating in a very different setup. And we wanted to produce something that was more relevant to the audience that work in a neonatal context. So that was the rationale for doing this. There's a number of questions in the chat, and as I go through talking about the paper, I'll perhaps pick up on a couple of those points. One of those was around the fact that of 59 papers that we'd seen that were eligible, 10 were included. And the question was around, does that mean that other studies were not following strict criteria? Now, I don't think that's necessarily true. I think those studies may have followed their own strict criteria, but they weren't the criteria we had for this review, which was specific to delivery room and neonatal units. So for those reasons, that's why those papers were selected. And in the Prisma diagram, you can see the reasons why the other 49 papers weren't, which might be that they were in the wrong setting. So for example, that was a baby that was intubated in an operating room by an anaesthetist, perhaps. So that's where why we selected the criteria we did and why we used the population we did. I wanted to come around to one of the main findings that we had, which also brings out a little bit around the difficulties within analysing this. So as you will have heard, the main outcomes are that there was an improvement in overall intubation success and an overall rate of first pass intubation success. And the overall rate had moderate certainty, but the first pass had high certainty. So why is that? Why is there a difference in the certainty of evidence between those two outcomes? And the superficial answer is you can go through the grade process and you score it all, and you can see that for the domain of inconsistency that overall intubation was rated as more inconsistent. It was rated as serious, whereas first pass was not serious. But why was that? So what we found when we went through the papers is that it's easy to know who's intubating if it's first pass, because by definition, it is one intubator. Whereas overall intubation might be the same person who's tried several times, Or it might be the one person has a go, and at some point after they're not successful at the first attempt, a more experienced person steps in. But there is inconsistency as to when that happened across different studies. So for some studies, one attempt didn't work, someone senior stepped in. Other studies, multiple attempts, and then someone senior stepped in. So that does affect the number of attempts to intubate, for example, and your overall intubation is, whilst you can work out what the chance was of that baby being intubated, the person who's intubated them has varied. So that you then have to start interpreting that a little bit as to what are you making of the results given that background. And there was one study in particular, the VOLT study, that had a very significant crossover of early stepping in of more senior people, which made us slightly less sure about our findings, which is why we also did, you'll have seen that there was the forest plot, the main forest plots, and also one where there was a study with a higher risk of bias removed, which was the Volts papers, or Volts paper. And the reason we did that was that when to address our concerns about variation in when a more senior person stepped in to intubate, if we took out the paper that was particularly confounded by that, did we still get the same outcomes? And we did. The forest plots are still statistically significant for, in fact, both outcomes, but particularly the overall intubation success rate. Yeah, okay. And then other things in the questions, and this touches on the point about the level of experience. So there's a question in the chat around successful intubation with traditional intubations to be lower than we've seen over the last 25 years. Can we know the experience of practicing pediatricians or neonatologists in the two groups? Were they comparable? It's a good question. Because these are randomized controlled trials, they are comparable in terms of the level of experience because you've got a group and they're randomized to either using the video laryngoscope or a traditional one. However, we still run into that slight confounding of what happens after the first attempt or the second attempt when someone more senior comes in. And that point feeds into another comment that's in the chat around actually, given that the majority of the intubators were more junior, should the title have been factored that in? So should the title have been improves outcomes or first improves intubation outcomes amongst trainees, for example, rather than a generalized population? So the reason why I don't think it should be is that we registered this with Prospero to start with. So you have to say up front what your title is, and then you do your search, and then you find what you get. So having done that, we found the papers that we did. And amongst those papers, there's a proportion of people who are more junior and a smaller proportion that are more senior. But it's not that all of the intubators were more junior. And actually, in the observational studies, there was actually a greater proportion of more senior people than there were in the randomized controlled trials. So the overall review does, in fact, take in all levels of experience. Which is why I wouldn't change the title to just amongst trainees. However, I think it is important to acknowledge, as we did, that this evidence is stronger for people who are less experienced in their intubation skills. And I think that allows the reader to try and interpret what's written and also interpret it for their own location and the people who will be intubating in their own setting. Couple of other things I just wanted to bring out, and this will address the point about what did we find challenging. So risk of bias assessments. The risk of bias assessments are you can look up lots of tools, and I would point you towards the Cochrane website for if you put in Rob2 tool into Google and search that, it'll rapidly take you to the Cochrane website, and there's some useful tools there, but they are quite long-winded. There's many pages and there's quite a lot of reading in there, and it takes a while to get your head around it. And one of the tools I found quite helpful is that they have a shorter version of the risk of bias information. And within that, it has some really useful flowcharts where it'll ask you a series of questions for each domain, and you just follow all the arrows through, and it will tell you at the end whether for that domain you should be rating something as sort of serious or not serious. And you can do that for all of them. And in a moment, I'll drop the link to that particular document in the chat, and you can have a look. But I found that quite helpful in working my way through the risk of bias assessments for all of the different domains for this. And if you are taking on a systematic review, or you just want to get your head around how risk of bias assessments work, then that might be something that's worth looking at. I also found Covidence very useful if you've not used it. I think it's relatively user-friendly, and it steers you through the methodology that we've heard about, which is where you have at least two reviewers that will screen the papers that have come out of your literature review, and then it kind of allows comparison. So if two people agree, something moves through from maybe a title and abstract screening to full text screening, and then you can pick out where there's differences in opinion. And I think as a software, I found that quite helpful. There are other versions out there, and I have no vested interest in Covidence itself, but I found that quite a useful thing. Um, Very happy to take other questions. Oh, actually, I'll just pick up on time to intubate as well. Um, so time to intubate, we did try and look at that, but it was quite difficult. And the reason for that is that it's not always for first pass intubation, it's maybe a little bit simpler, but people don't always define when does the clock start and when does it stop. Um, for overall intubation, are you counting the time from your decision to try and intubate until the final point that the tube is in place and you're happy that it's in place? Or do you stop the clock after the first intubation, maybe while you're mask ventilating and regaining stability, and then restart it when you try again? And it wasn't quite clear how time was being measured. And then when you actually looked at the raw data, for some papers, it took longer with a video laryngoscope, and other papers, it took longer with a traditional laryngoscope. And the other point possibly to consider is, whilst not spending too long in intubation is probably a good thing, I'd rather have a slower, safer intubation than a rapid one that was done in an unsafe way with profound bradycardia and hypoxia. So time itself may not always be the useful metric. I'll pause there because it may well be that there's questions people want to bring out, but I'm obviously happy to try and answer anything you want.
Uh, I think there was one question in the Q&A box, which Veera has answered directly to the person who asked the question. But maybe Veera, you could read out the question, which is in the Q&A box, the one that is about the deviations from protocol, which may not be recorded.
Yeah. So Naresh has asked my personal
Personal
view.
view, yeah.
Though every researcher has his study protocol before study, many of the times there is some deviation that from the study protocol, uh, but which might affect the outcome, like intubation. When whether it is available, whether suction is available, whether it is a difficult airway situation. So these might not be reported, and these might be affecting the outcomes. So yeah, you are right. I mean, we don't live in a idealistic world. So so these should be reported if the author feels they are real deviations. But remember, in RCTs, such deviations are balanced between the groups, right? So, if there are deviations, it should be reported, and this will be flagged in deviation from intended intervention in the risk of bias. Even in Robinsey, also you have that domain. So, PDA tolerate trial is a very good example where there was lack of physician equipoise. Almost, I think 70 or 80% did not stick to the protocol, which was informed in the paper. Yeah. I hope you got the answer. Sir, you want to add something else, sir?
I just wanted to ask Dr. Falk, both with trials that require some sort of intervention immediately after birth. For example, there have been some recent trials on delayed cord clamping versus early cord clamping, and whether you should, in patients who require PPV at the time of birth,
Mhm.
that and trials like this where there may be emergency intubations required. What are the challenges in randomizing patients where there's no time available to randomize?
Yeah, it's a
And
really good. Yeah, sorry. Did you have a back end to the question there?
no,
Sorry,
no,
I
that's
cut you
it. I
off.
just
No,
wanted
no.
your
Okay.
comments on that. I mean,
Yeah.
how
No.
do people handle these kind of situations?
Yeah. So it's a really good question, and it applies to many different areas of medical research. So there will be in adult practice studies that involve unconscious patients or cardiac arrest studies. For us in the neonatal world, situations at birth where you don't necessarily know exactly whether you're going to be able to randomize, or you getting consent is difficult. So it may well be that you can share information. Let's say we're talking about a delayed cord clamping study, and you're looking at delayed cord clamping in the context of a baby that needs resuscitation. So prior to that baby being born, you don't know whether they're going to need resuscitation or not sometimes. So how do we approach that? So it may be that for babies, situations where there is a higher chance they'll need support, prematurity, or other indicators, you can approach family beforehand, and then you can outline the fact that if their baby needs support, then you will randomize them into sort of delayed cord clamping or not, and you'd followed a standard pathway of trying to get informed consent. Now, we do also have models of deferred consent now, which have been through appropriate kind of ethical scrutiny. So in those situations, it may well be that you can randomize a baby into a trial, and then after that you will come back to the family and explain what has happened. Now, the safeguards to that process is that it's been through ethics committees and been deemed to be a reasonable thing to do, and that there is information available in the hospital that study is being run. So that is a methodology that is acceptable for emergency type situations where you otherwise would not be able to study that intervention. There is ongoing work around delayed cord clamping and resuscitation. At the moment, ILCOR doesn't, we don't have enough evidence to know exactly what the right answer to that question is. It is thought that if you have the ability to provide cord intact stabilization, then that may well be a good thing. But if that equipment and experience isn't available, then there may well be a priority towards resuscitation at the moment. But that is definitely an area of ongoing active research. The evidence for delayed cord clamping outside of that is getting increasingly strong, and is now moved across most global guidelines to be the default option unless there's a good reason not to.
Thank you. That was very illuminating. Uh, Dr. Cabra unfortunately had to leave the meeting because he had some other pressing commitment. He was going to tell us a little bit about the generalizability of the findings to his own unit. And I had a chance to talk to him before this session started. And he was referring to this whole thing about the experience of the intubator, because in his unit, he feels that the people who come in, they already have some degree of experience, and he has never encountered failure of first pass intubation rates as low as or the other way around, as was reported in the meta-analysis. So he felt that in their situation it was a little different. But I guess each center has to, I guess, make a judgment. It's uh, about the generalizability of the findings to their own center, depending upon how frequently intubations are done. Because I guess places that are low volume, where trainees don't get the opportunity to do many intubations, there would be an overall, lower level of expertise amongst the trainees where the volume is low. And there, I'm sure there would be a role for video laryngoscopy.
And of
So
course, as we've discussed, the move towards a greater use of non-invasive respiratory
that's right.
support
Yeah.
does mean that there is less intubation experience out there
Yeah.
for
Yep.
people.
Yep.
And there are, of course, whilst our paper didn't really look at this, there are other situations that video laryngoscopy is used. One is in sort of difficult airway guidelines. And there are difficult airways out there, and no matter how experienced you are, there may be some babies whose airways are challenging. And also for teaching. Now, the main advantage of video laryngoscopy for teaching is that everybody can see what you're looking at. So when you're describing, if you have a novice intubator and they're intubating, then we can all see where the end of the tube is and where the cords are, and help guide them to move them in the right direction in a way that you can't do with traditional laryngoscopy. So I think there are a range of different uses there for it, which extend beyond this sort of systematic
Yeah.
review.
Interestingly, we noticed a phenomenon that during the COVID pandemic, there were a number of units that purchased video laryngoscopes,
Mm.
more from the point of view of, that the intubator doesn't have to come very close to the intubated infant or neonate, to avoid the distance, which was, of course, a completely different indication for.
Yes.
Yeah.
Although I suspect the greater risk was probably from the mother than the baby, actually, in that
Yes, yes.
setting, in that it was
That's
more
what we
likely
got
the
to know
mother.
later during the
Yes.
pandemic that babies hardly. But the
Mm.
beginning there was when no one knew anything, that that fear was still there.
Yeah.
Yeah.
The other thing, I suppose, we talk about the experience of the intubator and how easy it is to intubate. There may also be the experience of the baby. Um, and, is it that actually the intubation rates are quite successful in some, when we're talking about the applicability of using video laryngoscopy and the feeling that in some units with high turnover that people are very slick at intubating. But within that, we're focusing sort of entirely on the intubator's experience. It's hard to know exactly what the baby's experience is like, and that may be tied into the length of time it takes, or the approach you take with the video laryngoscope, the size of the blade. But I think as medics, we probably focus on the intubator's experience rather than the intubatee, the person being intubated. Although I appreciate that is maybe a little bit harder
Yeah.
to assess.
Yeah. Okay. Thank you very much. We have almost come to the end of this whole session. Dr. Veera Raghavan, do you want to make any more concluding remarks before I hand over to Dr. Pratima to wind up the session?
There's another question in the Q&A. Uh, so, yeah, the question itself is an answer. Can you explain the difference between I square and tau square? Is it proportion and absolute value? I was just typing the mathematical equation. I think it will take too much of a time. Just to say, put it simply, always interpret your I square by eyeballing the forest plot. And with tau square, you can calculate the absolute variance. But tau square has to be interpreted with the effect estimate, whether you are calculating the mean difference or risk ratio or odds ratio, and the outcome, whether the outcome is weight or blood pressure or something like that. So you can search and find the answer, I guess.
I think Dr. Falk has also written an answer, addressed to everybody. So please look up his answer in the chat box. Yeah, and we have really overstepped the time. So I would request Dr. Pratima Anand to conclude the session on behalf of the National Neonatology Forum Research Committee. Dr. Pratima, would you like to say a few concluding words? Are you there? Okay, she may be engaged in something else. So I thank all of you, all the panelists, for having really enlivened this whole session and educated all the participants about the nuances of systematic review and meta-analysis. We had specially chosen this particular meta-analysis for teaching purposes because it was a simple meta-analysis. There was lots that could be easily explained. There were no complexities involved, and it dealt with a very day-to-day, real-life clinical situation that all of us face all over the world. So thank you very much to all the participants for having joined in. As you know, we have a monthly journal club, the NNF Journal Club, on the last Friday of every month. So the next one is going to be on the 26th of December. We'll let you know what the paper is going to be, and who will be the host institution and the external experts. Thank you, Dr. Falk, for taking out time from your busy schedule. Thank you, Dr. Veera Raghavan. Dr. Abhishek, you did a wonderful job with the presentation. And thank you to Dr. Nandkishore Kabra, who's not here right now, for having guided Dr. Abhishek. With that, I wish you a very wonderful day, and thank you all for joining. Thank you.
Thank
Thank you
you.
very much.